I hit the right button here. All right, it looks like we are recording. So before we jump in and introduce your speakers, I wanted to share who I was, because most of you, I'm sure, have been used to hearing Michelle Moreau on these networking calls. As most of you are aware, her last day with the program was last month. So to put a face with a name and an email, I'm Allison Antoine. I have been with the program for almost 4 years now. I'm located in Milwaukee, so you don't see my face a whole ton in Madison, but the next time you see me at a Cancer Council meeting or the summit, you know, this is what I look like, so feel free to come over and say hi. And I threw up my email there in case you have any questions. You can feel free to email me. So just a little refresher of kind of why we're here today. We will be hearing from the implementation grantees that were funded between, for about a 7-month period between 2018 and 2019. The program was able to fund 6 projects that were happening in a variety of settings, community health centers, and 1 hospital system, to work on decreasing cancer screening disparities, which is in direct support of the Cancer Screening Disparities Action Plan that came out of our current 2015 to 2020 state plan. And so many of you joined a call that we had in December where these grantees kind of shared an overview of their projects and what they had hoped to accomplish over their project period. And today we've fully wrapped up that funding period, and so we're going to hear from them about what went well, what they learned along the way, what they might kind of coin as a success story, in hopes that all of you on the line may be able to take kind of bits and pieces from what we hear today back to your organization and try to implement that. And then along the way during those 7 months, each of our grantees worked with Sherry Scott, our evaluator, to help plan and support some evaluation efforts of their projects. And the first group that we'll hopefully be hearing from today is Scenic Bluffs, although I think Amy was having a couple technical difficulties, so we'll see if she's on the line. Otherwise, we might skip ahead and then have to come back to her. So Amy, are you on the line?
Hey, I'm on the phone. I'm not able to see the presentation, but I have my own slides up. I can run through them.
Okay, well then when you're ready, just say next slide, and I have your title slide up right now with your team and the title of your project.
Okay. Are we ready to start then?
Yeah, go for it.
Okay, super. All right, so yep, so there were mainly 4 of us working on the project. We originally had looked at some research about low levels of cervical cancer screening in farm-based women. And so again, being in the communities that we're in, that seemed very relevant to us. Next slide. So what we really started with was what we called a deep dive. We looked at our data of our patients to determine what our kind of trends were with who was being screened and who wasn't being screened. We were surprised actually to find that our Spanish-speaking patients have a very high level of screening rates, where our English-speaking patients are much lower. And then we also found that insurance is a big factor as well. Uninsured patients are much less likely to be screened than those with access to insurance. And the Medicaid and private insurance, that was fairly close percentage-wise as far as compliance with screenings. So it really was the complete lack of insurance. Also, the age group that had the lowest rate of screenings was 45 to 64. So that group that's more at the end of the recommended ages rather than the younger group. Next slide. We decided then to target social and community groups, thinking those would be women who, again, were living in our rural area. We wouldn't necessarily know if they were going to be our patients or not, but we still were going to educate them on screening recommendations. We were going to do kind of pre and post. So when we first met with the group, we were going to ask them through just a quick paper survey if they knew what the screening recommendations were and if they knew if they were up to date, some very basic demographic information. And then after the presentations, we were going to follow up a couple weeks later and say, did you do anything about the information you learned? Our challenge is that most social and community groups in our area were not interested in having a speaker come talk about cervical cancer screening. A lot of the church groups we looked at, their memberships were age 65 and older, so it was irrelevant to them. Ironically, one of the church groups was interested and wanted to have us, but they weren't having regular meetings because the leader of the group was going through cancer treatments at the time. And so we did meet with one church group, and no member in attendance was under the age of 65. We also then kind of targeted what we considered like parenting type groups. Some of them were kind of play groups, some of them were book clubs, some of them were homeschool parents that got together. And those groups were the ones that did not want to, they were polite, but they did not want us to come talk about cervical cancer screenings. Some of them talked about how their group meetings were very focused, and so they weren't looking for education outside of whatever purpose they meet for. And other ones, especially the ones with young kids, said that they didn't feel like that was something they wanted to talk about with their kids present, and the way the group functioned, there was no way to separate the kids from the parents during the meeting. So that was kind of what we got. We just got a lot of no thank yous. We did go to a couple events we do some we do like biometric screenings with a local employer. And so for 1 month while we were going to those, we would talk to any relevant employees that were the right age and the right gender. We would talk to them about cervical cancer screenings. There was a health fair. It was canceled because of a snowstorm, but then we went to it when they rescheduled it. We found out at the health fair, everyone's happy to come over and talk to you, and they'll take the stuff you have. But if you ask them to fill out one of the pre-test, post-test cards, nobody wanted to fill one of those out. So we had some face-to-face individual interactions with people, but we really determined that the social community groups in our area did not want presentations on cancer screenings. We also then did a PR campaign, and a big push on it was our Facebook. And we have a lot of data on what worked and what didn't with Facebook posts as far as getting people to interact with the ads. I don't know if there's a lot of super relevant detailed information for anyone who's not familiar with how you use Facebook ads, but there's two different things we used. One was called a boosted post, and one is called a targeted ad. For those of you who are familiar with what those mean, the targeted ad was much more effective in getting engagement than the boosted post. And also we kind of found that, again, with these Facebook things, that the women at the higher end of the age range were more likely to see them and interact with them than the women at the lower end of the age range, which did kind of correspond with what age we were trying to target. So that was useful. Next slide. So then, because we didn't do a lot of interactions with social groups, what we did is we looked into our patient groups and looked at who had come in and had a PAP completed in the previous about 3 months. When you looked at that group, the number of women who had completed a PAP, and we just used coding for that. A couple challenges with reaching out to them is that we're a small rural community health center. It's not a high number of patients. Some of them are Amish, so you can't give them a phone call and talk to them about it. Some are Spanish speaking, which is okay because we do have Spanish speaking staff, but it just adds one more complication in trying to reach out to them and interact with them. We decided to look at the group of women. We pulled out anyone that was having additional follow-up after their PAP. We just figured if they were going through some concerns and things, we didn't want to talk to them about their PAP during that period of time. We ended up being able to reach and talk to 6 patients. 4 of them had a PAP because they received a reminder, whether it was in the mail or by email or a phone reminder, that they were due for one. And then 2 of them received the PAP because they themselves had scheduled a physical, just knowing they needed an annual physical. And then at that appointment, the provider said they were due for one, and they accepted that. So in those 6 cases, contact from a provider or from the health center was what initiated their appointment for a PAP. Next slide. So what did we learn from this is, one, that the whole reaching out to community groups specifically about cervical cancer screening was not useful. We talked about maybe in the future being more generic and just contacting them regularly and asking what's of interest to them and going out to them with that topic. And then eventually hoping that builds relationships, but us going at them with the topic was not helpful. That deep dive into data was incredibly useful, and I feel like we want to keep doing that. I don't know really what a regular basis would be, whether it's annual or 6 months, but just looking at what changes over time in different groups, subgroups of our patients is going to be interesting, and it'll also help us target patient groups. This was our first real heavy use of Facebook and really looking at the metrics that go with that. We're going to keep doing that and kind of compare ads over time, look at different times of the year, and try to really figure out what gets to people to engage with Facebook, and then also be more thoughtful about the links we use. What, you know, if someone's going to click on the link we offer, what are we linking them to? Is it just CDC information? Is it direct information on our website? What do we want to do with those clicks if we can generate them? And also what we're moving towards now is this idea of more of a patient survey. Again, those 6 phone calls we had were helpful and useful, and maybe we need to be more interactive with patients to find out why they are getting PAPs or why they do accept screenings, rather than just making assumptions about what's going to work and what's not going to work. And I think I have one more slide. Yep, and these are just the Facebook ads we used. The first one in the upper left corner with the pink, that was just the boosted post, and the only way to interact with it was just the regular like or share. And then the bottom one, the yellow one, that was the one that had the most interactions. And again, we don't know at this point if it was timing or if it was the ad itself, but we're actually thinking about rerunning that ad after a period of time, maybe next year or something, and just see if it gets the same reaction, or again, if it was just the timing period within which we posted it. So that was what we did. Thanks.
Thank you. Okay, so for the most part, we're going to take questions at the end or kind of through the chat box, but Amy does have to hop off. So if there is a question, I'll pause for just a moment here. Otherwise, if somebody thinks of a question once Amy's off the call, we can follow up and we'll get the answer out to you. So I will pause for a question if there are any.
I do have one question. This is Alyssa and Lily from Access. How did you make the ads? Was there a certain program that you used to create these Facebook ads, or did you have an internal department create them for you?
Yep, we have a marketing staff. So she created the ads, and the truth is I can have her contact you. I don't honestly know where like the images and stuff, I don't know where she gets those from, but I can have her contact you. But I know she was kind of pointed, like that bottom yellow one, she was trying to come up with something, you know, younger, the lowest level, you know, age group and stuff. She was kind of trying to play around with what might appeal to different ages. But if the details of it interest you, I can have her get a hold of you guys.
Amy, why don't you send me that information and we can share it with the whole group?
Yep, I sure can do that. Yep.
Thank you.
Yep, thanks, guys.
All right, thank you, Amy.
Yep.
And we are going to jump ahead now. From Cashton, we're going to go up to the northern part of Wisconsin and hear from NorthLakes Community Clinic. So, Emily, if you want to.
Yeah, this is Emily Caves. I'm our Quality Improvement Manager for NorthLakes Community Clinic. You can go to the next slide. Just as a reminder, we serve pretty much the entire top portion of the state. We're just over 20,000 square miles that we serve. We have 15 clinics right now, all very rural. Go to the next slide. For this project, we chose Iron River and our Ashland clinics to be our clinics of focus. You can go to the next slide. This is some pictures of our NorthLakes team. It was myself, our integration director, Annette, which is also an RN, Lori Cannon, which is an RN, and then Amy Botten, our quality improvement assistant. Next slide. So we targeted our Iron River and Ashland clinics because after diving into some data, we found that the colorectal and breast cancer screening rates throughout Ashland-Bayfield County were really poor for late stage diagnosis for both colorectal and breast cancer screening. So we really wanted to focus on both of those patients to improve our screening rates. Next slide. Throughout this project, it definitely transformed. We were looking at our target population, which is that 50 to 75 who receive medical services at our Ashland and Iron River clinics. Of course, we looked at the females for the breast cancer and then male and female for colorectal cancer screening. But as you'll see through this, and if you can remember back to our December meeting, the work transformed quite a bit. And it was such a heavy load on our data scrubbing that we had to kind of drill down to specific patients. So you can go to the next slide. So some key steps, what we started with is we utilized as our drives. So we extracted patients that were seen for a medical visit, were in that age range in both the Iron River and Ashland clinics. We really dove into those patients. We call it scrubbing. We scrubbed those patients to really look into their charts and see, like, are they truly due for colorectal or breast cancer screen? So according to Azara and the data that's in our EMR, it showed that they were due. So we really dove in to find, look in the narrative sections of the notes, see what conversations the patients had with their providers, if they're declining it due to whatever reason, or we found a lot of them were, I'll self-schedule, never ended up scheduling. And we found a lot of patients that had a screening done and didn't necessarily tell us, but we have access with our community partners, EMRs, so we can extract those records and get that loop closed into our in our EMR. So we found the majority of our time was in this. We did not think it would take this long to really dive in and scrub. Our current EMR platform, not super effective, but we actually are going through a conversion right now, going live to Epic in August. So we're really hoping that transition helps this work going forward to have like a more consistent accuracy of our cancer screening data. So from all that work, in the meantime, our marketing department was working alongside with our RNs on creating informative materials, radio ads, newspaper, and social media messaging. We had radio ads go out, newspaper ads. They sounded awesome. It's exciting when you're driving down the road and you hear one go off. Then from that data, so we identified those patients that truly were due for one of those cancer screenings. Then we performed outreach to those identified patients. We created a letter to patients, kind of more personalized letter to those patients. And then about 2 weeks after, a week to 2 weeks after that letter went out, if we hadn't heard back from those patients, then we placed a phone call out and to see like, hey, did you get your letter? Would you like to come in? Kind of understanding what engaged the patient best, that letter or that personal phone call. You can go to the next slide. So with our colorectal cancer screening, we identified, we were scrubbing through 307 patients. We kind of broke it down in a few categories, like patients, there were 60 of those patients that needed their records updated. So out of the 307, 60 just needed them updated. Like we didn't have the record back in, needed that loop closed. Patients, we identified a lot to not outreach to just for those grants. We're taking this in the future, kind of identify how can we better address this population, but we found documentation in the patient's chart that they don't have provider preference, or it's provider preference that the patient doesn't have it due to other risk factors, documentation of patient choice, that we are not their primary care provider. So lots of different items that we're going to take in the future to kind of identify. But then you can see broken down how the number of patients that we outreached via letter, we connected via phone call and they do want to do the screening, and then how many were disinterested and ones that we were unable to follow up on a phone call. You can go to the next slide. So overall with our colorectal cancer screening, out of those, I think it was 143 or 147 patients that we performed the outreach to, we saw a 5% improvement in the colorectal cancer screening rates. You can go to the next slide. And then this is the same with the breast cancer screening, same structure. We had right about 250 patients that we initially scrubbed, had almost the exact same number of patients that we did perform the outreach to. And they really were very similar, the number of patients for both cancer screening. You can go to the next slide. And then for breast cancer, we saw a 4% improvement in that patient cohort. You can go to the next slide. So some lessons learned, you know, the data entry was a huge thing. So we're really excited to get into the EPIC platform and really hope that supports our data accuracy in our work. The retrieval of results from community partners, that was really beneficial to identify some flaws and some gaps to really make that workflow more efficient. And then that ties into closing the loop. One thing that we're still just unsure at, which I'm super excited what Amy said with Scenic Bluffs, is those patient surveys. Like, we're trying to figure out how we can engage those patients the best. Like, those patients come in our clinic for those annual visits. We're getting them in, we're getting those screenings done. Most of them are doing that. Those patients that we outreach to, yeah, we had like 30 patients tell us they were going to. Not all of them did it. So how do we better engage those patients that we don't see regularly? So that's still kind of up in the air. We're trying to identify what's going to be the best method. So I'm really going to take what Amy had mentioned back, doing those patient surveys on who completed the screenings to try to benefit from that, identify how we can engage those patients better. And I think that is the last slide. Yep.
Any of them do pop up.
I'm having a hard time hearing the speaker. I don't know if anybody's talking right now.
Alyssa and Lily, can you guys speak up so I can make sure it's not your phone?
Oh, yeah, sorry. I guess we were waiting on questions,
Yeah,
but we're ready.
So no, that's not our phone, but we can hear it. Was it the person who presented prior to us? Hello. Can you hear us?
A question in the group chat from Regina asking me.
This is Emily. Sorry. For the response to some screen, the Cologuard is definitely more what a lot of patients wanted versus the IFOB. But we found a lot of patients, and we're kind of struggling with this, is patients that are screened positive for like the Cologuard or IFOB, then they have to go to the colonoscopy. The colonoscopy is not being covered by insurance because now it's diagnostic.
Ugh.
So a lot of patients are now like, well, I don't want to get that less invasive test because if it screens positive, I won't get the colonoscopy, or the colonoscopy won't be covered, but then they don't want to go directly to the colonoscopy. So we found that with a lot of patients, not a lot, but a handful of patients. So we're bringing that forward to kind of see how providers can have those conversations a little differently. And then the outreach for the breast cancer and colorectal were almost exactly the same. A lot of the patients, though, were women that were in the same age range, and they kind of killed two birds with one stone.
Great, thank you. Thanks for staying on for that extra couple minutes to answer those questions. All right, so I think now we will jump over to Access Community Health Centers in Madison. So Alyssa and Lily, take it away.
All right, thanks, Allison. So we chose to focus on cervical cancer screening and prevention, clearly. So you can go to the next slide. And so our project goal was to gain a better understanding of why our screening rates had actually been decreasing rather steadily over the last few years. And so we wanted to kind of figure that out by looking at our current workflow and identifying what our patients and staff perceived as their barriers. So the plan priorities that we addressed were reducing system barriers, improving patient education and navigation, and then providing staff education. And so to accomplish this, we hosted 2 patient focus groups. We conducted a deep data dive, as many other groups did as well. And then we also surveyed staff about their knowledge around cervical cancer screening internally. And then we also hosted 2 lunch and learn sessions for staff and kind of went over the results of the patient focus groups and all of that. So we can go to the next page. And so to kick it off, we formed the Women's Wellness Coalition Steering Team, as we called it. And that was kind of the core group of people who were looking into these efforts. And we also reached out to a few other community health centers and kind of asked them what their best practices were. These health centers we reached out to were some of the health centers that had currently the highest rate of screening. And then we also developed a partnership early on with Deborah Nevels of the American Cancer Society, who was really amazing to work with throughout the process. And she actually ended up facilitating those 2 focus groups and our 2 staff lunch and learns. And she was a really great facilitator. So we got a lot of great information from those. And just some other efforts throughout it. We solicited a few Madison businesses for donated goods so that we would have gift bags to give to our patients who participated in the focus groups. And we also designed and mailed 500 invitations for these focus groups, targeting women between 23 and 60 who are overdue for cervical cancer screening, but who have also been actively engaged in their care over the last 18 months. And then as part of the data deep dive, we looked at the trends around our patients who are overdue for cervical cancer screening, and we created a series of like infographics and charts that kind of highlighted the trends in insurance status as well as race, ethnicity, and language. And that was really helpful in showing our staff, especially, kind of the trends in our patients. So we can go on to the next one. And then Alyssa?
Yeah, so like Lily stated, one of our major activities that we did was hosting these kind of 2 women's wellness focus groups, one at our Joyce and Marshall Erdman Clinic and then one at our William T. Evu Clinic. And so some takeaways that we received from that was that the women at the focus group described their health as average, manageable, feeling frustrated about their health, and that the number 1 kind of barrier that we learned was that mental health was an issue as related to their health or receiving health care. Then we also learned that concerns with their health included that they felt that the medical staff not always knowing what to do with their condition was kind of frustrating, or they felt kind of at a loss. Losing weight was a struggle, not being heard by staff, and then feeling as if the doctor was always kind of looking at their watch and trying to just kind of get them through the appointment. Barriers to receiving care entailed feeling that their copay or visit charge was a barrier due to being unable to pay it at the time of service. Negative past experiences related to healthcare, whether it was at Access or a previous organization, feeling that they were unable to advocate for themselves, whether it was around paying their copay or discussing different health issues that they were experiencing. And then, as I stated previously, mental health and anxiety around following through with their appointment or even making an appointment to begin with.
And then the pictures on this one, the top thing is the front side of our invitation. You can just see we tried to make it a little bit more fun so that it wasn't just like getting a mailer from your clinic. And then the pictures are from the event. So we had like nicer snacks, and we really tried to make it feel like a very welcoming environment, and our patients responded really well to that. So next slide.
So then from our data deep dive, here was some kind of results from that. We learned that women in their 30s and 40s were more likely to be overdue for cervical cancer screening. Women in their early 20s, as well as their late 40s to 60s, are less likely to be overdue for cervical cancer screening, and women in their late 50s to early 60s being the very least likely to be overdue. So trends for overdue patients for cervical cancer screening, we learned that despite having Medicaid coverage, which covers preventative care, they were actually the second highest number of patients overdue for screening, which was kind of surprising. And then of course the largest group was women without health insurance. But this kind of gave us an opportunity to look at, although people have insurance coverage and they don't have to pay for a copay related to preventative screenings or preventative care, that they were still not coming into their appointment. So our initial, as thinking about potential barriers, one of which was, insurance, and we're like, oh, that could be a barrier to care. And we noticed that, about 1/3 of those patients actually had insurance. And then you can kind of just see here at the bottom that we had about almost 1,400 patients that were overdue for cervical cancer screening. And then 61% are ethnically or racially diverse, making them more at risk for developing cervical cancer. You can go to the next slide. So then, as Lily shared with you guys, we sent out a tester knowledge survey to staff prior to the lunch and learn session. And we asked them different questions related to our cervical cancer process and what they perceive as potential barriers to screening patients for cervical cancer screening. And so the #1 barrier reported by staff, so 66% of our staff, said that patients not thinking that cervical cancer screening is important, or they just weren't worried about it, was the #1 barrier to trying to get patients to come in for their PAPs. And the second barrier reported by staff, which was at 57% of staff, said that there wasn't enough time in the office visit to screen for cervical cancer screening. So if they came in, so if the patient came in for a visit, say that they came in for, to discuss refilling their medication. And at that time, at pre-visit work, they looked and they're like, oh, actually, you're due for cervical cancer screening as well. Do you want to do that? They felt that not all the time, if the woman was agreeable, that they would have time to actually do both in the appointment. So that was something that we saw as an opportunity that we could try to be more proactive when patients are calling to schedule appointments. So our call center knows what certain things that they could potentially be due for other than what they're calling for. So you can go to the next slide. And then, so lessons learned from the project. So our initial project goal was too large in scope. So we learned that some of the most valuable information we would have to look at kind of at a smaller scale, which actually was super helpful to kind of take a step back and do this data deep dive and really like get a good idea of, what these different factors are that are related to our decreasing screening rates around cervical cancer. And then we expected our patients' barriers to care to be things, as I said, like insurance or transportation. And we were surprised that across the board, everyone reported mental health as being the largest barrier in one way or another. We actually just pulled some data not that long ago that it was around 41% of patients, as we did this kind of deep dive of patients that were overdue and engaged in care, 41% of those patients had a diagnosis related to mental health. And so that was a huge kind of eye-opening thing that we might want to use a different way of kind of outreaching to patients, knowing that, you know, this anxiety or feelings of uneasiness to come in to get care in general is basically their #1 barrier. And then we also learned that at our focus groups, we presented them as more of like a pampering themed event with gift bags and fancier food. And the patients were super receptive to that, as Lily had stated, and we're super thankful. And I think that they, knowing that this was an event to kind of promote self-care and talk about, you know, themselves, which they might not be doing most of the time, since most of them are, you know, the matriarchs of their families, that this was really a time for them. And so we wanted to give back to them for being able to share kind of this important feedback to be able to improve their access to care. And then the results of the focus group indicated that our patients have a collective misunderstanding of their general vaginal health. And this accounts for many people being overdue. So what we learned is if our female patient ended up going to urgent care for a UTI or, you know, they had some vaginal discomfort, they felt that if the doctor looked at their vagina, they assumed that that was a PAP and they got screened for cervical cancer screening. So we learned that there's definitely some opportunity for some patient education around that as well. And then I think that's it.
Great, thank you, Alyssa and Lily. And in the interest of time, we'll collect questions and we'll address them at the end. So again, thank you very much. And I loved the graphics in your presentation.
I know, isn't that adorable?
So from Madison, we are now going to go to very southeastern Wisconsin, and we will hear from Nicole Hunt from Kenosha Community Health Center.
Good afternoon or good morning. I forgot what time of day it was. Can everyone hear me okay?
Yes, sounds great.
All right. So with our grant, Kenosha Community Health Center focused on a marketing campaign, both social media and print, and some outreach to address screening rates in African American males for colorectal cancer screening. Allison, if you can move to the next slide. All right. So we really wanted to increase education and awareness on appropriate screenings. We were targeting a specific population that showed trends of non-compliance. Kenosha did a deep dive into our screening rates for colorectal cancer, and we found that African American males living in zip code 43142 in Kenosha had the lowest screening rates across all of our populations. So we wanted to see what we could do to reach out them directly. The study we were using showed that multiple forms of communication have shown an increase in compliance. So we were hoping that we could have some of that effect in this project. I feel like there's something else I was gonna say, but I can't remember. So go ahead and move on to the next slide. So the other thing we were hoping to do is really study the impact of our outreach and marketing efforts. So we have done outreach in the past. We've done mailers in the past. Social media is relatively new for us. We've been working with a marketing company over the last year to really boost our online presence. So the other goal of this project was to use all of these in order to see where we could get the most influence and the most follow through for the resources we put into the project. So major activities, we did a mailer as well as an email reminder to patients. We had a list of about 1,900 that they were due for a visit and that they should be getting their CRC screening. And all of our materials were very specifically developed to target African American males. In addition to that, we did a social media campaign over the course of 6 months that focused on blogs, online quizzes, and Facebook ads. And then we did direct community outreach with some of our educational materials with our case management staff. So for the course of 4 weeks, they spent 2 days a week at a local nonprofit, reaching out directly to patients in our community that may need access to care. So with the mailer, we did do 4 engagements. So we did one initial mailer in April, and then we followed up with a second mailer in June. The second mailer we actually sent in English and Spanish to see if that would have a bigger impact. And then we did an email communication in June that was both English and Spanish. Social media, we did a combination of blogs on our website that highlighted information on colorectal cancer screening. We also did just general informational promotions that were on our Facebook page. The big thing we did was a test your cancer prevention knowledge. So it was a questionnaire that we pushed out online, and people could respond to it and answer questions and get more information. And then we did do some promotion around our CRC awareness event in March. What was exciting about this project is after we were running this, the quiz for a few months, we actually took the most common wrong answers and used that to update our marketing materials to specifically address the areas where patients were having the most misunderstanding. So we were able to shift our focus as the campaign went on. So if you can go to the next slide. So some of our results, and this is just a snapshot of some of the information that we collected. We did get a lot more detailed information on gender and demographics of people that engaged with different parts of this campaign. But what I can show you is for our online social media posts at the top, you can see the different types of posts we did. So our awareness events, our blogs, our quizzes, and then just our screening promotions. And then you can see the average number of individuals we reached with each type of online medium. So, and reach just means that someone saw it. So the average screening promotions had the biggest impact. We reached over 3,000 individuals on average with each one of those promotions. But as a result of engagement, so people actually liking, sharing, or commenting on any of our online posts, we actually had an average of 98 individuals engaged with our promotional event, where you can see the screening promotions only had 32 on average people engaged with them. And then the final thing that we thought was interesting is that our quizzes actually had the most clicks. So clicks means that someone actually clicked into the post and followed through with whatever links were available. And our quizzes on average had 32 people click through them every time we posted them. On total throughout the promotion, we had almost 100 people complete the quiz. So it did definitely show us that you can share information, but if you want people to take action, having some sort of quiz or information that they can answer or engage with is going to get a lot more people to click through than just sharing information. The other thing we did want to share here is for our mailers, we took a look at our screening rates. And you can see the second table there. Across the board right now, we have 31.9% of our patients are currently screened for CRC. And those that received the postcard mailers and the email mailers, there was a slight increase to 32.3% of those individuals being screened. But when we pulled this data at the end of June, we found that the patients who received a mailer and actually scheduled an appointment, the screening rate jumped up to 40.3%, which is a huge increase. So we did see that there was an impact in the mailers that we sent out. The other thing that is not here, but that I think is worth mentioning, we've done mailers in the past that have been very general. We've used more verbiage or just some standard images and templates from the CDC. This is our first time using a marketing company to develop messaging, and we got a 38% response rate on our mailers and email blasts. So out of the patients who received the information, 38% of them followed through and scheduled an appointment. In the past, we averaged about 10–12% of our patients would respond to our mailers. So again, that is a huge impact for us and a huge jump up. The other information I provided here, our email blast did not seem to have as much of an impact. So you can see the number of emails we sent and the actual open rates, you know, 14% for the first one we did in English and 15.6% for the second one. We did get a 25% open rate for our Spanish patients. So that is definitely a little more positive, but overall, not very many individuals clicked through. So once they opened the email, they did not actually click any links to follow the information. So I think that's an area where we want to continue to explore how we use that communication style effectively. If you want to jump to the next slide. All right, so lessons learned from this project. So the data showed that our target population was as compliant as the other populations in following through and scheduling an appointment. When we dug real deep into the mailers, we found that the African American males in our target zip code were responding and scheduling appointments as frequently as the other demographics. Cool. So overall, we did accomplish our goal in trying to reach out to this specific demographic and engage them with our clinic. The social media posts, on the other hand, did not have as big of an impact on our target population. Overall, more women, about 68% of them, engaged with our social media posts compared to the 32% of men. We did see a lot of success in the quizzes we did, and using that data from the quizzes to update and refocus some of our marketing materials based on the responses, I think was really useful. So I'm excited to find a way to use quizzes and interactive posts in the future because I think people really get excited about those. Couple of things we noticed as a result of this project that was unexpected. So we did notice that our mailers that went out, we targeted, you know, all patients who have been seen in the last 3 years that were within the age range. We found that there was a 5% increase in follow through for our patients living outside the city of Racine, or I'm sorry, the city of Kenosha, after the second mailer. So when we sent our first mailer out, we had about 29% of our patients from outside the city schedule appointments. And then after the second mailer, that jumped up to 33%. So there is an opportunity there in the future, I think, to target when we need to target patients outside the city, to know that a couple follow-up communications is what it's going to take to get them engaged. The other thing we thought was kind of an interesting observation is that our mailers and our email blasts had a higher impact on our Hispanic and Latino population and our Spanish-speaking population. So overall, the Hispanic and Latino population responded to our communications. 42% of them came in and scheduled an appointment, and the Spanish population scheduled, 43% of them scheduled appointments. I think this is definitely something that is interesting, considering the fact that our first mailer that went out was not even in Spanish, it was in English. And it wasn't until the second marketing blast in June did we update it to a Spanish language communication. So I think there is more to observe there and figure out why this was so impactful on that population. And I think that's my last slide.
Thank you, Nicole. So again, everyone type your questions in the chat box. I see we've got a good discussion going there already. Just so in the interest of time, again, Nicole, thank you very much. So we are now going to kind of head up the lake shore of Lake Michigan to Lakeshore Community Health Center, which is one of their clinics is in Sheboygan. And then we will be hopping from the east coast of Wisconsin to the west coast and closing us out with Gundersen Health System at the end. So we will first visit with Lakeshore.
So good morning, I'm Jenny Wensink. I am part of the crew at Lakeshore that has been trying to improve our colorectal screening rates, specifically for our underinsured patients, but for all of our patients overall. So next slide, please.
There we go.
Okay, so it includes myself, whoops, sorry.
We got a delay, sorry about that.
Our Chief Clinical Officer, Diane, one of our RNs, our CEO, our Medical Director, and then our Project Coordinator. So there's a pretty big group of us, but in the background, it is all of our staff, our medical assistants, our other providers, our RNs, our case managers that are also doing the legwork, even though they're not shown here. Next slide, please. So our primary goal was to increase those colorectal screening rates. And we started out between 37 to 45% among our uninsured. We had some really steady improvement, I think, and it went much better than we had originally anticipated it would. We thought we'd meet lots of pushback by patients. So in the the fourth quarter of 2018, we met 43% of that, and then the first quarter of 2019 was 48%. And by the second quarter of 2019, we were at 55%, and that's for our uninsured patients. Overall, though, between the patients 50 to 75, we wanted to increase our rate from 50 to 60%, and we did meet that goal, and even went above that in the second quarter of 2019 at 61%. So we're really happy about that data. It really was a team effort. Incidentally, we were able to improve all of our screening systems by just taking a look at how we're doing things, and specifically with this grant, how we could take some of the things we were doing for colorectal screenings and use them with our cervical cancer screenings or our mammograms and things like that. And we really were able to build team spirit, and we ended up having a great time. It ended up turning into a really fun experience for all of our staff. So next slide, please. Our first goal was to increase awareness. So what we did was we did some staff training. We did a CDC training for all of our medical assistants and our RNs. We provided our staff with some scripting of how to talk to the patient. We provided patient education materials in all of our exam rooms, as well as in our lobby and in our bathrooms. And we used messaging that was really simple and clear and concise. The results of that were, we did, along with the CDC training, we also were able to team up with Metastar, and we were able to provide all of our staff, not just the ones working in our medical department, but in our dental and behavioral health departments as well, with motivational interviewing training, which was awesome. It really went a long way to how we can interact with our patients and really put this on them and have them be interactive in it. We decided that every month we're going to do promote colorectal awareness in March, and continue to go on educating our patients, helping them find ways to deal with the cost, because that seemed to be one of our biggest concerns, and trying to have some fun and humor out of all of it. Next slide, please. So we did some system-based strategies, how to build a better screening process, how we're doing that, how to fix some workflows that just weren't working, using our reports, whether it be in Epic or in Azara, to track, and how we're going to perform follow-ups for those patients. So we added Azara reporting to our daily huddles. So every evening, our medical team huddles together It includes our providers, our BHC, our BH providers, our chiropractor, our medical assistants, our RNs. And we decided that we were going to add to our daily huddle sheet, we were going to track which patients we gave colorectal screenings to today, who was coming up on our schedules for tomorrow so we could anticipate those needs, and if we anticipated that there would be any issues with those patients. We also used some tracking systems with our reports to track why our patients were refusing to do either the colonoscopy or the FOBTs, and then we also offered poop on demand, and we actually had a few patients that were willing and able to do that, so that was pretty exciting. Next slide, please. So we made colorectal screening available at our clinic for $5, and the fee was waived if the patient could not pay that. We also worked with our other health system partners to find out how we could get our patients, if they did test positive, to get in to have a colonoscopy with it not being such a burden of having this huge medical bill after the screen was done. And so cost was never cited to be an issue for our patients. Either they didn't want to admit that, or that was not one of the reasons. It sounded like most of the reasons, especially for our older men, it was almost like a shameful thing, like this is not something I'm okay with. And so education really played a big part in that. Our chiropractor played a big role in helping review patient charts. So he would see a patient more frequently than our medical providers would. So he had offered to review their health maintenance topics when they came in to visit. And he would send a message. He would engage in conversation with that patient and be like, it looks like you're due for colonoscopy. We also have these other options available. Are you interested? If they were, he would send a order to our provider to get that ordered for the patient. And if they weren't, he also sent the provider a message saying this is why the patient said they weren't interested. So he played a huge role in helping us meet some of those needs of the patients that we don't see on a regular basis. We also implemented a program with privately donated funds that we were able to help people at that 200 to 400% increase access to having some of these tests done. And then working with the hospital systems to provide that charity care if they needed assistance that way. Next slide, please. Again, I talked about how we could make it fun, what we did. We used lots of different slogans or logos. Our medical providers are pretty competitive, and so they would often wonder where their numbers were at, what they were doing. We put bathroom materials out. We used a poop emoji costume that we would walk through our lobby in and kind of bring some awareness to our patients that might be waiting. We have poop emoji name badge holders, and all of our staff wear them, not just our medical department. So a lot of our patients would be sitting in the lobby and see somebody walk through and they're like, oh, what's that? Just to grab attention, get the word out there. We did follow-up letters, which were very helpful, and they included love your butt, colorectal cancer screening saves lives, and don't be a fool, test your stools, bring them in. Our patients would often come back in and comment that they were very catchy, and had it just been your basic letter saying, hey, you're due for your colonoscopy, they probably would have disregarded it, but it was something that caught their attention. Next slide, please. Lessons learned. So we use the team-based approach. We do this with everything that we do in our clinic, but it went just a little bit beyond our normal teams. It wasn't just our providers and our MAs and our RNs. You know, we engaged our case managers, our behavioral health counselors would often do education. Our front desk staff would give out the screening kits if a patient would come in and had also a script that they could use for some very general basic questions, and then our chiropractor. Our pharmacy distributed and educated patients about the kits that we use, and our pharmacists actually go through our patient charts and would also inform the patient when they were picking up their medication that, you know, we had ordered the kit or we had ordered the colonoscopy and we hadn't seen it come back in yet, just a friendly reminder. That went over really, really well, and the patients felt like they were not just a medical patient, but that their entire care was encompassed throughout our clinic, whether it's by the front desk, by our pharmacist, by our chiropractor, or by our medical provider. We will continue to use our Azara reports to monitor our health maintenance, and we will still be doing the huddles in the same way that we have been, even, you know, with this grant ending, and continue to do the all of the things that we're currently doing and try to incorporate those into our other health maintenance topics. Next slide, please. Advice that we would give, it really was not difficult for us to do this. It seemed initially like it was going to be a lot of work, but we're doing it on a daily basis anyways. And so it's just putting something, you know, prioritizing some things. And this was one of those things we needed to prioritize because our numbers were not where we wanted them to be. The small changes seemed to make the biggest impact for us. It wasn't, we didn't have to spend a lot of money or do a lot of extra work. It was simply just getting back to basics and doing the things that we normally would do, but just in a more clear, concise manner. Next slide, please. So overall, I think we had some really good short-term results, but it's going to make some long-term changes to our procedures and our flows. It was a fun experience, and I think that all of our staff benefited, and because of those benefits, they can now, our patients are going to be able to get better care at our clinic. Hello?
Do you want?
Oh, I'm sorry. I had you guys on mute. I'm so sorry.
Okay.
We're going to go to Gundersen Health System now on the west coast of Wisconsin and hear about their lung cancer screening project.
Great. Thank you for everyone that's still hanging in there. Our approach was a little different than some of what was done previously described. We wanted to do some work around lung cancer screening, and we targeted our HUD homes in the city of La Crosse. And we know that the smoking rate is higher in that population. Go ahead and go to the next slide. So we sent surveys out to everyone living in La Crosse's lower income HUD homes. And we know that the smoking rate in that population is about 35%. We also, so we sent surveys asking about their knowledge of lung cancer screening, how to get screened, their knowledge of, we also put some e-cigarette information in here, an e-cigarette knowledge assessment that I won't talk about today, and then what the barriers were for them around lung cancer screening. If they returned this survey, they got a $10 gift card from us, courtesy of our foundation. And then at the same time, we ran some PSA media campaigns. We had a billboard up for a couple months, some radio ads, and for several months, and then we also ran some commercials on Facebook and YouTube. Go ahead to the next slide. Here's a picture of our billboard. It was up in one of our low-income neighborhoods that got high visibility. Go to the next slide. I think it's our, and if you would click on this, this is a PSA that we developed. It was developed by our marketing department. It's only 35 seconds, so.
You can also look at it again if the sound didn't come through, but it ran on our Facebook and also was on LinkedIn and a couple of other places as well. And then it's running on our TV commercials. We sent out about 690 surveys, 700 surveys. We got back about 28% from this high-risk group, which we feel like is a pretty good response rate. And 44% were male, a good percent, 16% non-white, a lot of people with low income, low insurance, 60% Medicaid or no insurance, low level of education. So our survey was written at a 8th grade level. And then smoking rate, a quarter of the people that returned the survey were current smokers and 43% former smokers. Despite that, only 11% of the folks that returned the survey fit the tight eligibility criteria for lung cancer screening. So we just asked about their tobacco use, how long they'd smoked, and how much they smoked to get pack years. Go to the next slide. We did look at barriers and knowledge by whether or not they were eligible for screen, but we kind of determined that because it's so tricky to calculate pack years, for the purposes of this table, we're looking at ever smokers, so current or former smoker versus never smoker, to look for some differences here. And the main finding with these barriers, and you'll get these slides so you can look at this in more detail, but is that what we thought were going to be the biggest barriers for our folks for why they don't get screened, like they don't have a way to get to appointments, they can't afford appointments, or they don't know where the appointments would happen or how to go about that. It was really more about stigma. If I get lung cancer, it's my own fault. I don't want to know if I have lung cancer. And those were the things that kind of popped out as the main barriers. So next slide. And here's just some of those broken up by current, former, and never smokers. So if I get cancer, it's my own fault. I'm afraid to find out. If I had it, I wouldn't want the treatment. Certainly all higher in the, and that stigma is certainly higher in the current smokers, much higher than we thought. Go ahead to the next slide. So our lessons learned were that that we really need to talk with our staff about implicit bias, and kind of we came to this conclusion because at the same time we did this other survey of our healthcare providers, which we're not showing you the results here, but we talked with our healthcare providers, surveyed our healthcare providers about why they think their patients aren't being screened or why they don't necessarily offer screening. And our providers, for the most part, indicated that the patients couldn't afford it, or they wouldn't have a way to get to their appointments. So very logistical, kind of our assumptions. But our patients are saying that they're not worthy, or that somehow they caused this problem. And so we feel like there's a real mismatch of maybe what between our providers and our patients. And so we're going to really kind of dig deeper into that and look at stigma, and potentially also talk with our patients' loved ones who are, you know, have probably always been the ones to nag their parents about smoking. And so can we use them kind of as a lever to get to our high-risk patients? And then we're going to be also working with our marketing department to create more local stories around early detection. Doesn't mean early death. It means better survival, and that you really are worthy of better survival and better treatment. Next slide. This is just a picture of we got some free promotion at the same time that our billboard was up. Lung Association had a billboard up. And it was also in kind of a high traffic, low socioeconomic area. And then the next slide is just a picture of us as we were stuffing surveys. So this is some of our team members. So that's a real quick synopsis of what we learned from our project. The e-cigarette knowledge information was also really interesting, and if folks are interested in that, we can share that.
Thank you. And thank you to everybody who presented and everybody who's still on the line. We still have over 20 of you on the line, which is great. So at this time, let's open it up for a few minutes of questions. Either chat box will be reporting out on any of those questions that come through the chat box if the presenter maybe had to jump off, as well as sharing the recording. Any questions? Okay, we have one in the chat box. Gundersen, thanks, beautiful video. Did you find that most folks sent back info for the gift card?
So this is Dr. Polewski, Peter, also on the team here. Majority did send back, and we gave them a gift card as well. But as you saw, 28% kind of replied based on our sample size, roughly. And we didn't find any, impetus that they would actually reply due to just the gift card itself. It seemed as though that was just kind of part of our initial kind of packet. So we didn't really look into the meaning as to why they sent things back or not.
Thank you. Did you have folks ask about follow-up or getting screened? I think that's still to Gundersen.
We did. Our initial, it's a little too early to tell at this point, but that's a good question and something that we're going to follow over time here, because I think the initial impact of our PSA and our campaign will kind of fill out over time. And so we're going to continue to monitor that. But early on, we did have several of the recipients of the packet call in to find out more information. And so we'll track that over time.
Thank you. Any questions on the phone?
I think the other thing that I just would like to add with what Dr. Polewski said too is one of the things that is a little bit trickier is that we did this as a community PSA, so this didn't just go to our own patients. So we did also reach across the board to Mayo, which would be our other major health institution here in the La Crosse area, to let them know that this initiative was taking place. So what we would hope, I mean, we can track over time, hopefully that there'll be an influx with the screenings within our own internal system, but we would hope that the same thing would be seen within the Mayo system as well.
Thank you. Okay, last call for questions. Okay, final slide here, and thanks for hanging on a little bit past our time. We will be sending out some follow-up after this webinar, so be on the lookout for that. We'll share some of the resources that were mentioned and that were asked about, as well as the recording and the kind of history of the questions through the chat box. Our next webinar is going to be next month, August 8th, and the topic will be on e-cigarettes and tobacco in Wisconsin, presented by a couple of our other Cancer Council members, Sandy and Darcy. So look for registration on that. And then, as always, we'd love for you to stay connected with us via Facebook or Twitter. And I think everyone shared their other social media handles, so it might be fun to kind of start following each other. Otherwise, thank you all for joining. Thank you for your patience this morning and dealing with some of my technical difficulties. And we will be in touch. Have a great rest of your week.
Thanks, Allison. Bye.